survival among node-positive disease. Also, with regard to extended lymph node dissection templates, 3% of nodes in these extended, super extended templates were not in the standard nodal dissection template. The presence of node-positive disease in the extended templates were higher for T3, T4 disease. And there was also some role of frozen section to determine lymph node dissection extent, with a concordance between frozen section and final path of 99%. With regard to molecular subtypes for neoadjuvant chemo selection, a study showed upregulation of DNA repair mechanisms which signified chemosensitivity and predicted PT0 status. 3 separate abstracts found very similar results, and molecular subtypes predict staging and survival. Luminal and basal tumors were downstaged with neoadjuvant chemo, but only overall survival was improved with only basal, and P53-like tumors had a poor prognosis regardless of neoadjuvant chemo. So take home here is understanding DNA repair mechanisms and molecular subtypes have a future role for neoadjuvant chemo selection. And finally, the long-awaited results of the RAZOR trial were presented. This was a multi-center phase 3 randomized trial of open versus robotic cystectomy. No difference in their primary outcome of 2-year progression-free survival, as you can see here, and overall survival. There was no difference in overall margins. However, there was an association between the robotic approach and higher soft tissue margins. No differences in nodal yield, complication stage. Robotic patients had lower blood loss, transfusion rates, and length of stay. Open cystectomy had a decreased operative time. So the take home here is that robotic cystectomy is not inferior to open cystectomy with regard to 2-year progression-free survival and overall survival. However, robotics did have increased soft tissue margin, and we'll have to take that into consideration moving forward. Thank you for your attention.